go ahead and get started. So the first question I have today is, could you start by giving us an overview of your role as a neurologist and interventional pain specialist? What does your practice look like day to day?
So I'm a neurologist, and after that, I went on and did the headache fellowship, and then after that, I did an interventional pain fellowship. So predominantly, what I do, kind of my practice is predominantly I see patients with headache disorders and various kinds of pain disorders, and then I also see some inpatient general neurology, and sometimes like I tend to see like patients who come for headache or pain, they tend to have seizure disorder or a movement disorder, I manage them. So I tend to have a whole spectrum of neurology, headache, and pain medicine.
So with that being said, and with being triple board certified, what made you want to do a fellowship in headache medicine and interventional pain? To my knowledge, this is my first time ever hearing of that combination of fellowship and residency. So could you talk a little bit more about why you chose that route and what influenced you in medical school or residency to go in that direction?
So when I started neurology residency, initially I wanted to do interventional neurology, where like good stroke and stuff like that. But rotating in that for like 3 or 4 months, I ended up not liking the lifestyle, even though I was passionate about doing it. But I did not like the lifestyle because you're always on the call and everything. I felt like I was not meant for that. So later on, I had a rotation immediately after that. I was in headache medicine. So, and then I really loved it because like people are getting better because before that in neurology, you're like, okay, patient have a stroke, okay, start a medication. But unfortunately, if we don't catch them in the right window, they ended up being disabled or having stroke symptoms, and some people get better with rehab and stuff like that. But when they're there, so it's so hard to go back to normalcy. So that's when I saw like, okay, headache medicine is a field where in neurology where people are getting better. Like you treat them with Botox, and around the time where newer migraine medicines came in, and then people are getting better. They are saying that, hey, my life is completely changed right now. I could not work because I was having chronic migraines, and right now with this interventions, my headaches are better, so I can work back and go back to work, and then I enjoy all the things that I was enjoying before. So that made me more interested. Okay, hey, this field is extraordinary and it's great. So I wanted to do headache medicine. But during that time, in my rotations with my headache attending, so I had patients who comes with headache, but they said that I have neck pain, I have back pain. So we ended up referring them to interventional pain doctors for injections or ablations and stuff like that. So that made me choose as interventional pain medicine as an elective later on. So I did an elective during my residency, and I was like, "Oh, this is great!" And when this is much better. I love to do procedures, so I can do procedures in this, and people are getting better. And then you can do a various. Interventional pain medicine is a whole spectrum where you treat with medications and some simple trigger point injections in the office, or you can do something like a joint injections and maybe do some more injections under fluoroscopy. And then there is something like you can do some minimally invasive stuff like there is a procedure called MILD, something called SI joint fusion. These are minimally invasive and like spinal cord stimulator. So you can be doing a little bit more in the OR too. So it starts from something simple in the office to the whole OR. So I got interested in that. But I did not want to just restrict myself to pain, interventional pain, because I thought like headache could is an added part of it, and I think I was very passionate about it. So I wanted to do both. So I ended up doing both the fellowships.
Yeah, that's so the funny thing is, I've been able to watch neurosurgery and where they do the actual like spinal fusions. And so I was actually talking with my cousin a few weeks ago. He just started as an attending and he's doing interventional pain. And he was talking about how the minimally invasive spinal fusions. So it was really cool to see how much medicine has advanced to where you can go from a super invasive procedure to a not like very non-invasive. And I know you just started being an attending about 3 years ago. Could you talk about the improvements and the innovations that you've seen through medical school residency and fellowship and now being an attending?
So I can tell you the one thing, like the migraine wheel, right? As I was saying before, when I started medical school around that time, migraines, the treatment of migraine were like we took medications, like some of the seizure medications, and started treating migraine. Some of the antidepressants and started with migraine. There were no specific migraine preventative medications. The only medications that was called triptans were the only ones that were used as an as-needed medication. There was no other medication that was migraine specific. But later on, in around like 2018 and early 2019, there's this new medications called CGRPs came out, and they have changed the whole field of migraine, how we treat migraine right now. So that has been the biggest I have seen in the migraine realm, like what happened with it. And then coming back to interventional pain, during my residency days, predominantly we're talking about epidural injections, radiofrequency ablation, spinal cord stimulators, pumps. But I did not know much about the minimally invasive stuff. But later on in my fellowship days, that's when I learned about there was some minimally invasive stuff like there's something called decompression. It's a mild procedure. That's one thing. And there's something called SI joint fusion, like sacroiliac joint fusion. It's a minimally invasive where we can fuse the sacroiliac joint. But earlier there was a huge fusion done before, but this is something changed. And then later on during my early part of fellowship, there was another procedure called intrasep that came in. So that's one thing I learned. And then there is a huge innovation in the spinal cord stimulators field. When I started, it was open loop, but right now there's something called a closed loop technology that's been there. And there's something called like a peripheral nerve stimulators where instead of putting the leads into the spinal column, you can put this leads into the peripheral nerves in the body. So that has been a new thing and it has been rapidly changing since then.
So you talked about migraines having a huge improvement with this medication. For students who may not know much about headache medicine, what type of conditions fall under that umbrella, and how can you differentiate between a migraine that can be treated with a medication compared to something that could be worse? Because oftentimes headaches can present very similarly. So how do you differentiate between taking an extra step or prescribing that medication?
So headaches can be two things. One is it's either a symptom of an underlying condition. Like for example, if somebody had a brain tumor or a brain bleed, the most common symptom that presents is a headache. So it's a symptom in there. But sometimes there are some disorders where headache is a disease by itself. It's not a symptom of a disease like migraine. There are other, we call them primary headache disorders. These are migraines, and second ones are like cluster headaches, paroxysmal hemicrania, primary stabbing headaches, nummular headaches. There are a whole spectrum of headaches. These are, we call them primary headache disorders. So of these ones, they vary in intensity and the frequency of the headaches. Like migraine, there can be a simple migraine, people who might have one migraine per like once or twice a year. So for those patients, we don't give any daily medication. You just give them an as needed medication. Some of the times as simple as ibuprofen or Tylenol will take care of it and they are good with that. But on the other side, there are patients who has migraines like almost every day. And these migraines are like refractory to a bunch of medications, and these are the patients who ended up having some of like more aggressive measures, like Botox injections are one of the common things we do with migraines. And then these injectable medications, the CGRP medications I was talking about. So some patients get either Botox or the CGRP injectables, but there are patients who get a combination of both together. So just saying migraines, it can vary from one spectrum where one headache per year to like almost everyday headaches.
So with the Botox injections and a lot of the interventional injections, are they done under ultrasound, CT, or how is that done exactly?
So ultrasound injections for headaches are very if we follow a protocol, we don't need a thing. It's a blind, I mean, not a blind injection. We identify it's on the anatomical basis. So we'll go by anatomical basis. Like there's a protocol, preempt protocol. That's the name of the protocol. We go by it. So what it is there are four injections here, the frontalis muscle, There is one injection in one of the muscle called procerus, and there are injections on two muscles called corrugator muscles, and then there's a muscle called occipitalis. We inject 3 injections there. Paracervical muscles, and there's another muscle called trapezius, so we inject them. It's like 31 injections in total, and it's like landmark-based technique. It's not ultrasound or CT or anything like that.
And so it's done into the muscle and not like the nerve, or is it near the nerve, or how is that? How is
So
the placement within the muscle?
it's in the muscle, but the thought process is there are multiple nerves there too. So we are basically decreasing the transmission of the neurotransmitters that causes the pain in very simple terms.
Yeah, that's really cool how we've advanced so far to where we have a better understanding and we can take better precautions to kind of differentiate between certain headaches and migraines and things like that. And kind of going off or going to other interventions with medications. I know you're involved in advocacy for non-opioid pain management strategies. Can you talk about what that looks like in real life and how you approach pain control and minimizing risks?
So for me, the biggest thing before treating anything, I feel like the most important thing is diagnosis. So once you have a clear diagnosis, then your treatment is very easy. So that's what I concentrate on with the how to diagnosis first. And then once you have a clear diagnosis, then treatment goes on the next step. And then once you have a clear diagnosis that, hey, this is a chronic pain disorder, like maybe arthritis of the back, and there's nothing else going on that's causing the back pain. So I have a clear diagnosis of that. And then we know that there is nothing like an immediate surgery or anything like that that can be done. That's when I feel like it's a chronic pain which need to be treated with a multidisciplinary management. So I don't think just one kind of an injection or one kind of a medication would help with that. It's always a combination of stuff. So I'm a strong advocate for physical therapy, and then like mindfulness and things like that. That's one part. Second part is medication. There are various kinds of medications you can treat pain with. So one of the most common ones are muscle relaxers. The other ones are anti-inflammatory medications, and the third one are like neuropathic medications. So we can treat them, most of the pain with these, and then you can try injections, various kinds of injections. If none of them works, then maybe considering surgery. But for some reason, there is an increasingly use of opioid medications happen in between that causing so many problems in the patient, and with addiction and substance use disorder, a lot of things happen. I'm not a great fan of using that for chronic pain, and I feel like I think there is a role for them in some patients, maybe around surgery or acute pain and stuff like that. But I try to get away from chronic pain with opioids.
So would you say the best course for chronic pain is physical therapy or doing these interventional procedures?
Yes, it's a combination of them. So like the multidisciplinary care, having good physical therapy, having some strategies like mindfulness, some people like yoga or Tai Chi, some kind of an exercise. And in addition to that, supplementing that with medications and then injections if needed.
So I know from experience, like I've had to partake in physical therapy, and I know sometimes it's hard to stay consistent. How do you make sure your patients, or how do you make sure patients in general stay consistent with that? Because I know it's oftentimes easier to take the easier route with taking over-the-counter medications, or if it's prescribed medications to kind of relieve the pain. But that's only short-term improvement and not the long-term improvement that you get from physical therapy.
True. So my approach, like when I see the patients the first time, I try to educate patients more why I think physical therapy is important. Even, I mean, when I give them medications or when I decide on a procedure, I really try to educate why physical therapy is important. Like for example, right? Just imagine when you're working on a computer, right? You come like this all the time, holding your head like this. What happens is your posture is not great. So you end up having a lot of neck pain. This is a very common thing we all experience. So, but if you just imagine patient, somebody who already has arthritis and they're doing like that, it's going to make things worse. So first thing, and medication is going to help them long term? Is the injection is going to help them long term? Not. The most important thing is strengthening those muscles in the back. So treating them, teaching them the right posture. So physical therapy helps in that a lot, like helping them learn a good posture so that they're not worsening their arthritis and strengthening their muscles. But as you said, the biggest challenge comes in like how somebody can be so consistent with physical therapy, right? Because you have to go there like twice a week, it's painful, stuff like that. So this is what I would say, hey, if it's too painful, try to take a medication, go there and then do it, and then come back, take it easy for a day or two, and then do it. So I try to maintain a constant relationship with the physical therapist I send commonly to, so that they give me the feedback, hey, this patient does not, I don't think we are going anywhere, maybe consider an injection because they're not tolerating the physical therapy. So I do an injection and then send them back to physical therapy so that they can do the therapy. But what I tell my patients to, hey, once you finish your physical therapy, or if you cannot do it, at least do home exercise programs. So my physical therapist, they give them a clear plan. Hey, this is what you can do at home, and then they start exercising at home. I think that makes a significant factor.
Yeah, actually had a similar experience today. I was doing physical therapy because I have a like underlying foot condition. So the funny thing with that is I'm also doing a research project on it with orthopedic surgery. It's with accessory navicular syndrome. So it's where you have like a small or a slightly large bone that's access to your navicular. And so today, when talking with my physical therapist, it was like there are operative ways and there are non-operative ways, and physical therapy and getting custom orthotics or better shoes are those non-operative approaches. And also while doing my research, I've seen that that's been the better success, especially with strengthening the muscles around it, so you're not putting as much pressure um, on your feet as well as your hips as well. So I've firsthand seen how crazy that physical therapy can improve so much more than just trying to mitigate the pain with medication or anything like that. So I definitely completely understand what you're saying with how great physical therapy can be. But moving on to the next question, could you talk a little bit about just your journey, your medical education, residency, and how education in India kind of differs and what's also similar from here in the US?
So I was born and raised in India, and that's where I went to medical school. So the medical school there, I think the getting into medical school, it's so competitive, but at least it's a straightforward process. And then it's very early. So after your 12th grade, you like an entrance exam. So which like where I wrote my entrance exam, I think probably like 50,000 or 100,000 people wrote it, and then you are given a rank. Like whoever gets the highest one gets the first rank, second rank, third rank, and then depending on your rank, you get into the top medical college or the second one or the third one. So it's fairly a straightforward process. So you read, you study, and then you write this exam. This is in addition to your 12th grade boards and everything. After that, you take this exam and then you get a rank, and depending on that, you get into the medical school, depending on where your rank is. So it's a straightforward process to get into medical school. And then after in medical school, it's a little bit different from what we have it here, is because we have a 5.5 years of course total. Of that, 4.5 years is your medical school, like which involves your rotations and everything. So after you're done with your 4.5 years of medical school, there is a 1 year of mandatory internship. So meaning where you are an intern, but you rotate through pediatrics, you rotate to ER, you rotate to internal medicine, surgery, OBGYN, and everything. And then once you finish that 1 year, that's when you become a doctor. Like you get like the equivalent of MD, we call it MBBS there. That's when you get it. After that, you go into residency of your choice. So one of the biggest advantage there, I would say, is you get into the medical school very young, so you don't have to go through the undergrad of 4 years. And then during the medical school, the biggest advantage is having that 1 year so that you can use that 1 year to make sure that, hey, this is what I want to be. Like, for example, in your medical school, okay, I want to become an internal medicine doctor, but that 1 year will really help you to be to solidify your interest that, hey, I want to become an internal medicine doctor. Or if you want to go to ER, that 1 year will be an experience where you want to go to ER. So I think that was one significant difference, and one thing I saw an advantage was. So that's when I did my medical school, and then after doing my medical school, I decided like I want to come to the United States because I have my family here. So I came as a visiting student here. I came to Detroit, and then I was a visiting student here, and I really liked it, like how the evidence-based practices are, EMR, and then how thorough everything was, and the opportunities, the training, the research experience, a bunch of stuff. So I decided I want to come to the United States. So after that, I took all my US MLEs and then came here, and I mean, I always wanted to do neurology. That's one thing I knew from the start, is like I wanted to do neurology. During my medical school, all my research and most of my electives and everything was predominantly in neurology. So I came here to in Pennsylvania. It's called Geisinger Medical Center. That's when I did my neurology residency. And when I came here, I wanted to do interventional neurology, as I said, do stroke and everything. But as I told, like I did not want to do that. I ended up doing headache and pain medicine. And I wanted to go to a place where I can do both at the same place, so that I don't want to move from one place to other after 1 year fellowship. So I went to University of South Florida, Tampa, who had both headache and pain fellowship. So I did both of my fellowships there. And after that, I came to Columbia.
So I'm sure you've worked with students here in South Carolina. How would you say, from hearing what they experience with applying to medical school, um, is different or harder than or easier than applying to medical school in India?
I think everything has its own challenges. I don't think we cannot compare it. Uh, but I think the biggest advantage here is you get into medical school after really knowing what you're getting into, because at 16 or 17 years after high school, like it's when you're not that mature to decide that to become a doctor or what you're getting into, it's so hard. So I think that's the biggest advantage. You have that 4 years to decide whether what exactly you want, so that you understand life better and everything. So that's one thing. And then the hardest part compared to what my Indian experience is, you have to do a bunch of stuff here, right? It's not like you're taking your grades and MCAT, but you get to do shadowing, and then you get letters, you get to the interview process. I feel like that's an extra thing that you have to do compared to my experience getting to medical school. But I think this experience is a great experience. I mean, I think it's a great way to get into medical school, because by having the shadowing experience or being with the doctors, you're really having a real-time experience of what your lifestyle is going to be as a doctor, and how committed you have to be. So and then so you know why is it important to become a doctor? You become a doctor not just for the sake of money or anything, right? You get into this because you like to help people, and then you want to do something for the people, and then I think that the happiness you get by helping people, I think that's what I think most of the people wants to get into medicine. And I think you really see that, and then you will decide whether this is something you want to have or not. So I think that's a great experience. And then I think interviewing is also a great process of getting into medical school, because that is an opportunity for people to see, hey, whether this person is the right candidate for this school or this place, or etc. So I think from that end, I think it's a great experience.
Yeah, and from my experience, I know coming into my freshman year of college that a lot of students were pre-med, and now being in my junior year, a lot of people kind of figured out that this isn't the path that they want to go on. In India, you kind of don't really have that choice, especially with starting medical school at 17 or 18 years old. So I think I've really appreciated that. And I know in high school, I was like, I just want to go straight to medical school, but experience in college, you kind of also grow and understand what you're really getting into, as you said, and um, figure out the best way that you study so that you can be successful in medical school and you have these 4 years of undergrad experience of things you get to do outside of just healthcare. Like it doesn't need to just be shadowing, but you can do other things outside of that, whatever your passion may be. And my experience from hearing from my mom about her experience in medical school in India is that she didn't get to do like things outside of just medicine. So I've definitely been very, very appreciative of that alternative, being able to do something that I'm passionate about outside of just doing medicine that I'm also passionate about. But so what would you say is your most challenging part of your journey?
Challenging part. I think that initially my transition from back home, coming here, it's a new culture. So it's a new language, and I mean, you speak it back in English. English as you speak and talk. I mean, it's always in there. That's what you learn, but it's not your primary language that you talk with your friends or anything. So that's one thing. And culturally, it's a little bit different. And then EMR was not used to EMR. So those things were the initial challenging years for the first few months. But after that, I think it was not a big problem.
Yeah. So could you walk us through kind of what a typical week looks like for you when you're on clinic and then when you get off of work, what do you do to kind of relax and recoup for the next day?
So I work from morning Monday to Friday. So I get to work and then I come in from like 8 to 5 of work, come in the clinic, seeing patients on Monday, mostly like doing evaluations, like follow-ups and new patients. And then I get home and I have a 2-year-old daughter, so I look forward to going home and then be there and I play tennis. So that's where I try to relax and I like a little bit of cooking. So something I try to cook sometimes, like maybe 3 to 4 times per week at least. My wife is also a physician here, so sometimes it's good. But I mean, she's an intensivist, so she works week on, week off. When she's working, it's a little bit busier. When she's not working, we get to have more time. So that's generally after work. This is what my Monday is, and then Tuesdays I do procedures all day, Monday to evening, and Wednesday mornings I do clinic patients, like new patients and follow-ups, and Wednesday afternoon I work with USC for the admissions process and everything, 6 months a year, and then on Thursdays I do procedures all day. Friday mornings I do clinic, like seeing new patients and follow-ups, and Friday afternoon I try to do education stuff and my research stuff and everything. And then Saturdays and Sundays, and most of the time I'm free. And as I said, I like to play tennis. I like to hike, go around, and then I try to explore the Columbia scene, like the restaurants and stuff like that. My wife likes coffee, so we like to explore all the coffee shops, try to find new coffee shops. We make a point to go to India Coffee at least once a week. So something we do.
Yeah, I've definitely enjoyed the coffee scene or coffee shop scene here in Columbia. There's a lot of options actually that have great coffee. Like
It's getting better.
I've
It's
gotten
getting
really
better
into
from
coffee. Sorry.
It's getting better in the last 3 years. When I
Yeah.
first came here to now, there's tons of options.
Yeah. I've gotten a little bit more into coffee, not like as a hobby, but it's just something like that kind of piques my interest to know about the coffee and different types of ways of making it and all that. So, uh, definitely. So, I know you talked a little bit about your research, like you mentioned it a little bit. Could you talk more about kind of the type of research you do and the research you did in medical school and kind of why you wanted to keep doing research as an attending physician?
So I like clinical research. I don't do bench research. So my research is all clinical. So for me, research is like if I'm doing something, I have a question and I don't have an answer for it, trying to find an answer for it. That's my research for me. So all my research has been the same thing. When I was in undergrad, when I did medical school, we had so much of traumatic brain injuries. So like there was a bunch of highways up there, so and we had always had like road traffic accidents and stuff like that. So that was my interest of like traumatic brain injuries, what I did research on. And then later on, at the same time, my second project at that time was educating college students there on how to prevent road traffic accidents, like educating them on that. So that was my thing. And then during my residency, I had similar projects too on education and in education. And then whenever I see a patient, if I had a clinical question, I try to answer it. If I don't find an answer, then I try to do a project to figure that out. So that's exactly what we did. And during my fellowship is when I really, really got interested into research. And I can say an example like there's something called status migrainosus, meaning if somebody has a headache and that lasts longer, and then if they cannot take any medication, they end up coming to the ER and then treatment. But around that time was COVID. So nobody wants to come to the ER. So the idea was like, how can we treat that at home? So we looked up a bunch of protocols and stuff, but there was no much research on it. So we tried to do an extensive systematic review of the literature and came up with a bunch of protocols, and we published on that. Same thing during my pain fellowship. Whenever I had a question on something like, hey, I did not find it, so we did research on that. Same thing even right now. So if I run into a clinical question, I don't have an answer for it. So I try to do a literature review and then see if we can have an answer for it. If I don't find an answer for it, then we try to do a research, be it a literature review or a systematic review, or be it like a retrospective study or be it a prospective study. So answering any clinical question, that's what I do. So that's what I try to. I don't go beyond looking for a question in my routine practice. If there is something I have a question, we try to do that. Like for example, last year we did a small project on like when I was talking with the residents, they did not have a great approach on when somebody's on this newer medication, what if the patient who's a woman wants to become pregnant, how to educate them on it, when to stop this newer medication. We don't have, because we don't have a lot of data, like what this medication can do to the fetus. We don't have a lot of data on it. So we did a project on like with the residents, hey, how is your knowledge on it? And then we educated the residents on it, like neurology and OBGYN residents. And then we did a post survey on it. So this was a simple project where we were able to identify the knowledge gaps and then teach the knowledge gaps, and then able to do a survey later on to see how the education helped, and we are trying to publish that. So whenever you have a simple question, so trying to answer that is what research too.
Yeah, so my question was going to be, I know with MD PhD route, we do a lot more research-based than clinic-based, or seeing patients. So I was going to ask, how do you balance your time with being involved in research, your at-home life, and then also in clinic? And then you answer that with what anytime that you have a question, or sometimes when you don't know something and there isn't much research or information on it, that's kind of when you approach the situation with trying to figure it out. And I've never actually thought about it like that. Like with being involved in clinical research right now as an undergrad, I can't really think from that perspective of what the attending is thinking with seeing these patients and not really seeing like why this is happening. And then from that you kind of figure out your own question of what you want to solve. With lab research, it's a little bit different because there's a lot more minute things that you may not know about, or certain pathways and stuff. So I've with being involved in both lab research and clinic research, I've seen the differences and the similarities, and I find both really interesting. So, um, but yeah. So with your journey, would you say there were any key mentors or patient experiences or turning points that shaped the way you practice today?
I think my mentors has been a huge influence on me. I think at every point of my life, I think there was a mentor. I think I look up to or learn from and reach out to even now. I think everybody, like when I was talking with one of my mentor who's a chair of a department, he says that he has mentors right now. So I think that everybody needs to, I mean, we will have a mentor in a way, one way or the other, because these are the people who will guide us to do. So when during my medical school, I had a great mentor who really helped me decide on what is when I want to come to the United States. Look, hey, this is where you want to go. If you want to go back here, this is what you might do. So he helped me navigating the process. And then I had a mentor to come to United States, to come here and do my residency, hey, the whole process and everything. And then during my residency, I had great mentors. I think they are the ones who really, really helped me to become a good neurologist, and they are the ones who really helped me to go to the right program, and then and excel in what we do. And then the same thing during my fellowships too. I had mentors who helped me get into the right practice, what I want, and then to guide me through that process. And then after coming to being an attending to, I had mentors like, for example, you don't get to know a lot about billing and insurances and stuff like that. So I had mentors who I was reaching out to during my initial attending days, how to figure this out and stuff like that. And then now during my research process, like how to do research, if I had a question, like how do I navigate this process? And you always run into these questions, right? So you don't have a formal teaching after some point of time when you're an attending. So this is when you reach out to your mentors from various places or where you are right now to get those answers. So I think my mentors has been a significant part in shaping my career and even now, and I'm pretty sure in future too. So that's why I really like to be a part of now, to mentor if somebody asks me for something, from advice or anything, because I think that has really made me what I'm today.
Yeah, I think the reason we think mentorship is so important, that's kind of why we started doing PhysiLink and trying to connect residents and doctors with undergraduate students and high school students. Do you have any advice for undergrads or high school students trying to find mentors? It's very easy to find mentors within undergrad or people that you're just classmates or upperclassmen that you meet, but trying to find mentors in the profession that you want to go into or the specialty that you want to go into is a little bit more difficult. So what would you say is the best course of action to do that as an undergraduate student?
I think as an undergraduate student, I definitely feel like it's might be hard, but I would say what you guys are doing is a fantastic thing in that PhysiLink, because you know people. So like for example, whoever is following your undergrad who knows about PhysiLink, I'm pretty sure they can reach out to any of the speakers who are coming and talking to you guys, because they all know that these are the people who might be willing to mentor. So finding resources like this is helpful, like whoever are involved. I think one of the other things I recently had, I can tell you an example, is like an undergrad student at USC reached out to me on LinkedIn saying that, hey, is it okay? Can I come and shadow you out of nowhere? I never even thought that. So I think that has become, I think that is a huge advantage, right? LinkedIn is a great resource to reach out to people, write to them and asking them. So first of all, I feel like the best thing to start is like, okay, so this is what I want to do. If you decide on it, or if you're not sure about it and you want help in making that decision, I think you should not hesitate to reach out to people. Okay, for example, if you said that I want to become a doctor and you're not sure about what specialty or anything, and then I would start with people who are on education side, because these are the people who would be more willing to mentor, right? Because that is the reason they're mostly in this education. So I'll reach out to people like that. But you'll be surprised sometimes, like people in private practice or anything who are not in education too, they are also will be more than willing to be a mentor, because sometimes people are like, okay, they want to help, but they don't have an opportunity to do it. So I think if you email them or reach out to them, I think you'll be surprised. Like there'll be a ton of people who might be responding to you. So I would say, do not hesitate. Do not hesitate to reach out to people. That's what I would say. So maybe in undergrad, you can start with people who got into medical school from the same school, and ask them, hey, who are the people where you can rotate or things like that. And then maybe reaching out to those doctors would be the first step. And then the second thing is you can, I mean, go to on a website like USC School of Medicine website or Prisma Health website, and then start looking the doctors. And then if you find an email, you can emailing them. Finding the emails is hard sometimes. That's why I feel like, because I had a similar experience when you're trying to find an email, it's so hard. That's why I think that LinkedIn is a great resource to send an email, I mean, send a message, and then try to be connected with people.
Yeah, I know. I'm very fortunate to have a parent in healthcare who works at Prisma, but I know some students are first generation for applying to medical school and becoming doctors. And I know Prisma has kind of not a rigorous way of getting to shadow, but there is a process to go through, and private clinics don't have that. So I think definitely reaching out to the private clinics to shadow. And also, if you want to own a private clinic in the future, you can kind of ask questions about that and figure out what that's like. Because I know I've talked to a dentist with his own clinic, and he kind of discussed about his whole process of it. And honestly, physicians are very open to answering your questions. It's just all upon us to reach out and ask the first question. And like you were saying, LinkedIn is really, really good. Like I just made my LinkedIn about a month and a half ago, because of kind of like TEDx picking up and things like that. So I put that together, and it's been a great resource so far with reaching out to business owners and people within Colombia to communicate and work with them with TEDx and other things. So I definitely agree with making the first move is definitely scary in terms of reaching out to physicians or professionals, just because you feel like not necessarily that you're beneath them, but you feel like you're pestering them by reaching out to them, because that's just kind of the way that undergraduate students think. But honestly, I feel like physicians more likely than not are just here to help us out and get to wherever we want to be. So absolutely.
You
And
know,
so
undergrad is not the only time you're going to feel like that. In every stage of your career, you might feel like that. So I think not hesitating to reach out to people is a great way to start with. And you'll be surprised every time. Like there'll be a lot of people who are willing to spend some time and mentor. And everything.
yeah. And I know you talked, or you mentioned the admissions process and how you're starting to work in that process on Thursdays, I believe. So, what is it like to be on the other side and see students apply to medical school? What you guys are looking for, what you guys aren't looking for, what makes a applicant stand out compared to not?
So personally, this is what I look into, or what I feel is the best thing is, hey, how passionate is this person? And then if this person is passionate, what did they do? If you say that you're passionate, but you don't put that on, I mean, see that on your profile, like you did undergrad, okay, you did great, but you're so passionate for the 2 years, you did something else completely unrelated to it and not put in the work, doesn't seem like you're passionate. But I feel like if somebody is passionate and trying to do something so that they gain some kind of a skill in becoming a physician, or maybe an educator, or maybe the business of medicine, something on that line, I think that adds a significant value in how I see mentioned with the scores and everything. So I think that's what it is, how you invest your time, how focused you are. So this is what I see. I mean, working as an MA, yes, that's a great thing because you're learning a lot of skill, right? You're being talking with the patients, you're trying to do some simple stuff, you become a phlebotomist and being a part of in the healthcare and you want to become a doctor. So what really makes stand out as if somebody is doing something in learning skills to become a better doctor. It can be in any way. So I think that's what I feel like is a great thing. It can be different things, but on the lines for the healthcare.
So going off that, I know secondary essays are a little bit more direct and kind of what you're looking for,
Mm.
but I think a lot of students are uh, afraid, not afraid, but have that huge obstacle of writing your personal statement, your primary essay. So do you have any tips from what you've read as a good personal statement or one that needs a little bit of work?
I think that I mean, if you all get into this stuff, right, writing that essay is the hardest part, but I think telling your story honestly, I think that is a good starting point. And then you can probably make it more interesting. That's where your writing style and how you communicate it. But giving your honest story makes it exciting, I think.
Yeah, I mean, with juniors thinking about applying soon or seniors in their gap year or however many gap years you have taken. I think that's probably one of the bigger obstacles that I think a lot of students see, just because it's a very it's not very objective. It's a very subjective part of your application that can either really help your application or hurt your application. And I think trying to guess what admissions committees want to see is a trap that students fall into rather than just talking about your life, your experiences, and how that's turned you into who you are and why you want to be a physician. And I think that's what it kind of boils down to, instead of overcomplicating it and playing this like guessing game of how do I look the best instead of just
So
saying
this is what I always think, like a personal statement. Like if it is not something on your CV or a resume, and you want to tell somebody about you or your story, why you want to do this, I think that's what they say is.
I agree. I think
It's so simple to say it, but you have to think through it. See, you right. I mean, you have to think through it and then write it.
yeah, I mean it's like one of those things with interviews, it's like just be yourself. Like it is the most cliche thing to say, but I mean at the end of the day, that is what it is. Um, just being authentic is a word that a lot of admissions committees or students use. Um, but yeah,
Authentic and the biggest thing, right? So it's like everybody wants to be authentic, but again, the anxiety of being in that environment and things like that makes it different. So I think a little bit of practice and then trying to be in that position multiple times sometimes takes the anxiety off it and try to give your best, I think.
and do you have any tips with interviewing? I know we talked about it briefly just now, but are there any certain things that make an applicant stand out in terms of what they say or body language or things like that within the interview?
Something, I mean, everybody is quite different. Personally, for me, what I think is if somebody, I mean, practicing is okay. It's because we all practice, right? So that's the only way you get better because to take that anxiety off and stuff like that. Having a genuine answer, you don't want to say something completely different from what you wrote on your application. So I think that's when like, okay, this is not genuine at all. That's what you feel about it. So being yourself, being honest about it, and then clearly communicating it. I think that's the most important thing in any interviews, I think.
And so I know a lot of students and applicants get very nervous within interviews. What do you think the best way to kind of get rid of those nerves or try to use those nerves to strengthen your interviewing skills? Because it's inevitable that you're going to be a little nervous applying to potentially the medical school that you want to go to and interviewing for it.
So I would say the best thing, first and most important thing is doing mock interviews with people who you don't know. Being comfortable talking with some stranger and doing a mock interviews is very helpful. And then this is what I would say, sometimes like reach out to people to just ask for, hey, and these are the mentors, right? They really help you. Hey, can you do a mock interview for me? To see how it is and then ask, I mean, they can ask you complex questions and stuff like that, which you are not expecting. So trying to answer that will help you to be in that scenario even before the interview. So that's very helpful. And second thing is do a good research on where you're going about the medical school, everything about the medical school. If you know who are going to be the interviewers, learn about them. And then I think always in an interview, you want to have a point where you can talk about and have a conversation, right? If you cannot if you cannot keep up a conversation, that's where the interview goes bland. So either you have to keep the conversation going, or if the interviewer is trying to keep the conversation going, you have to understand it and then go with the flow. So if the conversation doesn't flow, that's when the interview becomes more there is nothing much exciting. But if you make the conversation more flowing, then I think that's when most of the time interviewers will remember you, and then you will stand out from all the applicants that day. Hey, because there are a bunch of applicants the same day, right? So when the conversation is flowing, I think people tend to remember you more, and then I think that you'll stick out from other people.
With knowing your interviewers, and I know at the end they always ask, do you have any questions for us? What do you think they're looking for whenever they ask that question? Like, what type of questions should you have prepared, or what should you do before the interview to not be flustered or to not say that you don't have any questions to ask?
See, sometimes I don't feel like saying I don't have any questions is a bad thing, right? Because you, I mean, for example, if I'm the last interviewer of the day, you might have got all the questions answered by now because there are already a million people you have spoke with. So that's okay if you don't really have a question. But I think if you have any kind of a question, there's nothing wrong in asking. Like, for example, if somebody doesn't have any question about, for example, if I'm interviewing for their MD school, I don't find it wrong if somebody asks me a question about completely different from admissions or the medical school. If they ask me about a question about my practice, there's nothing wrong in it because they might have already got all their questions about the school and everything. So I feel like it is okay sometimes not having a question. But the biggest comes in when you don't ask the questions. You're like, oh, are you not interested in the program? It's not. That's the only problem that comes to it sometimes. But I don't think there is anything wrong if you don't have a questions. But again, if you have a question, it's an opportunity for you to ask a question. So it's a great opportunity, right? When somebody asks you, like, do you have any questions? And you're coming for an interview to learn about the program. So somebody should not feel bad about asking a question. So
Hmm. Yep, that makes sense. And so, as we get to the end of the webinar, this is the last question that I have. Keeping in mind most of our viewers are pre-med undergraduate students, what advice would you give them in general and for someone who wants to explore neurology, headache medicine, or pain medicine for the first time?
so I would say as a general advice, make sure that you're learning a skill every day. Like not an every day, like you cannot learn a skill every day, but whatever you're doing, you're trying to learn a skill. I think that's what you need to know. If you're rotating with somebody, you're trying to learn something from that. You're not just there. Maybe how to interact with the patient, how to interact with the physician, or how to, when you're learning, like as simple as like how to just talk with the patient when something. So that's a skill to have, and it's a great skill. I still feel like the way I talk with patients changes with the years coming in. So I think constantly thinking about how you can improve your skill to become a better doctor is one thing I would be a general advice. And I think deciding on headache or pain medicine or neurology, I think the best way to do it is by rotating with physicians. So we all have passion, but I am a strong believer that if you don't like the lifestyle, your passion will go away. So I think you should have a passion, and then you have to also have like the lifestyle of that specialty. So I would say is once you get into medical school and then rotating with that specialist, or even in the undergrad, rotating with that specialist to know what exactly they do. I think that is the only way to know that's the right thing for you or that's what you want to do or not. But I think you should try to rotate it in everything possible.
Well, with that being said, we truly appreciate you being here this evening and taking the time to share your experiences and insights. Is there anything else you would like to add or say before we end off the webinar?
No, I wish you all the good luck for all of you guys. I think you guys are doing an extraordinary job having this PhysiLink. I think I was super impressed at what you have guys have done, and I think this is a great way of letting everybody know who doesn't have mentors or who doesn't know. I think you guys are doing a great job.
We
Thanks
appreciate
for
that.
inviting me.
And a recording of this webinar will be available on YouTube sometime in the next week or so, but it would also be on Spotify as a podcast. And on that note, thank you again. This was honestly a great conversation that we just had that I learned a lot from. I got some of my questions answered that I already had, and then some questions that other individuals wanted answered as well. So I hope you have a wonderful rest of your evening, and thank you for joining us today.